Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent funding from Novartis.
Hello, I'm Samia Mora. I'm a cardiologist at the Brigham and Women's Hospital and professor of medicine at Harvard Medical School. Today, we will be discussing incorporating LPA routinely into cardiovascular risk assessment, why, what, who, how, and when. And joining me today is Dr. Eric Stroes. He's a professor of cardiovascular medicine at the University of Amsterdam in Amsterdam, Netherlands. Welcome, Eric.
Thank you.
Today, we have an exciting discussion about the incorporation of LPA into cardiovascular risk assessment into routine clinical practice. And we're under a timer, so it's a quick fire format. Eric, you'll only have a minute to answer each of these questions, so the clock is ticking. Let's get started. Before I ask you the first question, Eric, I wanted to briefly introduce the epidemiology and burden of LPA. So high LPA levels are actually quite common. Worldwide, there are about 20 to 30% prevalence of having high LPA depending on geographic region and ethnicity. And as you can see here, the risk threshold is about more than 30 milligram per deciliter where the risk goes up, but above 50 milligram per deciliter is where the levels are associated with what's considered high LPA levels. Now, genetics provides a very strong support for causal continuous association with LPA, regardless of ethnicity. And the strongest associations are actually for myocardial infarction and for aortic valve stenosis. Lifetime risk for MACE increases with higher LPA. So because it's a genetic factor, we have it all our lives. It's predominantly genetically determined. And so the risk is really lifetime and starts when we're born. And it increases with time, of course. And the higher the LPA level, the higher the cardiovascular risk. So why measure LPA at all? Well, first, it's causal. Second, it's common. As I said, about 20-30% of the population contributes to cardiovascular risk, but also risk of aortic stenosis and other diseases. And we can act on it now. We'll discuss all of those today. So, Eric, maybe we can start with a case example of a patient of yours.
I would love to. Let me introduce a man of 48 years. He's, body mass 24, normal blood pressure. His cholesterol is, pretty good, actually. LDL 128, which is basically 35th percentile for his sex and age, so low. But there's one thing, a family history, premature atherosclerosis. His father had an MI at the age of 52 and a brother an MI at the age of 58. And basically had some non-specific complaints, went to cardiologist, he did some checking, found nothing, so exertional, stress testing, all negative. So he presented to my clinic and he said, so what's my risk? And basically he was very motivated to understand. So we discussed that for him, there was hardly any risk factor. All the factors we always ask, smoking, diabetes, etc., there's absolutely nothing.
But he has a family history.
But the family history is there. So what are the unknowns? Well, might not be surprised LPA was unknown, but actually what we did in him, because he wanted to know, we made a CTCA, and here you can see a CTCA, age of 48, the right coronary artery, proximal lesion, where you see spotty calcification and low attenuation, black, right in the beginning. And most importantly, when we measured his LPA, it was 374 nanomole per liter, which is approximately 150 milligram per deciliter. So that was what we could discuss with him.
So what, in your opinion, Eric, are the consequences for this patient of having such a high LPA?
Yeah, well, one, we could explain to him that high LPA is a risk factor, so this could absolutely be one of the risk factors in his family. And mind you, just for interest, I mean, LDL is in the millimolar range and LPA in the nanomolar range, so it's by far inferior. But recent data actually showed that the increase per 50 nanomolars Lp(a) is much higher, like 6-fold higher than 50 nanomolar LDL increase. So it's the atherogeneity per particle which gives this a special negative ring. And if we actually calculate the risk, you can see in this patient that only looking at lipids, you can say that his 10-year risk is 5%. If we add in his calcium score, which was 78, with the MESA, we can see that it's now 10%. But most importantly, now we learned his Lp(a), and if we look at the famous paper by Florian and co-workers, and you, Samia, we know that his baseline risk of 10 is multiplied several fold. So he ends up in a risk of nearly 30% lifetime risk, which does explain that here we're facing a really special condition which needs some action.
So the key is that it's multiplicative risk.
Yes, on baseline risk.
Yeah, and what do you think should be done for this patient, Eric? What did you do for him in the clinic?
Yeah, that's the best question, right? A lot of colleagues say, well, what can I do? Because there's no Lp(a) lowering approved yet. Well, here you can see that if you, for instance, estimate his lifetime risk till the age of 80, you fill it in, you can see that his baseline risk increases with the genetic Lp(a) clinical guidance.com. It goes to 60%. And if you see then, if you model a lowering of 60 milligram per deciliter of LDL lowering and 10 millimeter mercury blood pressure, then you can see that you can reduce that risk from 60 to 30% until he is the age of 80. So basically, the call for action is be aggressive in traditional risk factors. You can't take away the Lp(a) risk increase, but you can significantly attenuate the overall cardiovascular risk. So that's exactly what we did. We said you need good primary cardiovascular risk modulation.
So it's key to reduce the patient's overall cardiovascular risk.
And explain it to him carefully. And I know you do a lot of stuff all over the place, primary prevention, just a little teaser. Lifestyle, we always say lifestyle. There is no evidence on lifestyle changes in high Lp(a). But Matthijs Boekholt, a friend and colleague of mine, he looked in Epic Norfolk, and indeed, patients who have healthy lifestyles have much less risk. So also for high Lp(a), we think that good lifestyle may also severely mitigate the increased risk. Now, Samia, can I ask you, do you have another example of a patient where Lp(a) really modifies your way of action?
Yeah, I have a great example. So we have a 67-year-old Black woman, and it came in with a history of dyslipidemia. She's obese, she has type 2 diabetes, also has coronary disease, significant coronary disease. In fact, she's had like multiple percutaneous coronary interventions, has had an MI in the past. And Lp(a), we measured it because she's in my clinic, and we found an Lp(a) level of 60 milligram per deciliter.
Which is not massive, but increased.
Yeah, moderately elevated, because as we said earlier, above 50 is considered elevated for milligram per deciliter, and corresponds to about 150 nanomole per liter.
So, and what did you do with this moderately elevated Lp(a) level for her?
Yeah, so for her, it carries risk, right? Because she already is high, very high risk. She already has history of cardiovascular disease. She has multiple risk factors, obesity, diabetes, and now this moderately elevated Lp(a). So the first thing I think about is what's the patient's risk? She's high risk. And a level of 50 milligram per deciliter, like we said, is the cutoff, which is about 125 nanomole per liter. That's the cutoff for what's considered high for Lp(a). Hers is 60, so that roughly corresponds to about 1.5 or 50% greater risk. So I multiply that by her overall risk. So let's say her overall risk is, say, 20% because she's second-year prevention. Then you can multiply that by the 50%, and now you get a 30% absolute risk. And these patients are, in particular, the ones who have cardiovascular disease and have a high Lp(a), even if it's only moderately elevated, they're at a high risk of recurrent events. We know that from the studies. And in fact, this is the population that never gets tested, Eric. Unfortunately, in the large registry studies in many hospital systems, only less than 5% of patients.
So recurrent events and interventions.
Yeah, even having cardiovascular disease, etc. Very, very few get the Lp(a) tested, and that's what we really need to get better at.
Yeah. Okay, that's highly interesting. So, and what did you do therapeutically with this patient?
Well, as you and I were on the co-chairs of the EAS statement, which has now really been disseminated, we have some very specific recommendations. So first, we tried to control all the cardiovascular risk factors. So we discussed about her obesity, her weight management, about the diabetes to make sure she's on all the modern therapeutics like SGLT2 inhibitors, GLP-1 agonists, etc., all to reduce cardiovascular risk. The other thing is I was more aggressive with her in terms of her lifestyle. And with lifestyle, it's hard to change people's behavior. So you have to discuss that with the patient, and it's a shared decision making, how much you can build up on it slowly. In particular, these patients, I like to screen also their family, or at least discuss with them that their first degree relative should be also checked tested. Yeah. And she has children, so we discussed checking the LPA levels there. The FDA in the US also about a year ago did approve lipoprotein apheresis for patients like her who may have still an elevation, recurrent event, yeah. And also has a high LDL cholesterol in addition to having an LPA more than 60 milligram per deciliter. But that's not available everywhere.
No.
So Eric, can you tell us now in less than 90 seconds, what's the impact? I know you can do this because this is your area of expertise. What's the impact of LPA on plaque and coronary plaque?
Yeah, and I love the question because this is exactly what we have to explain to patients. This is not just another risk factor. A lot of preclinical work shows that if LPA is high, your first line defense endothelium is inflamed, which is bad news. Mm-hmm. You have monocytes are activated. And if you look up patients who actually get a carotid endarterectomy, you can see that there's inflammation in the specimen. So it's a very active adverse effect on atherogenic lesions.
And do we know how that happens?
Yeah, it's all because of the oxidized phospholipids, most likely carried by Lp(a). They inflame, they activate a lot of cells. And when we do actually imaging studies, you can show that in LI Lp(a), the arterial wall is like inflamed. Mm-hmm. It's active, which is obviously a risk factor for atherogenesis. Mm-hmm. And more recently, now it's getting fun because now we know we do the CTCAs, right? Mm-hmm. And cardiology is moving so fast. Okay. So with CTCAs, we can actually now with very good accuracy, we can see unstable lesions. And one study in particular was really interesting. If patients have higher Lp(a), they have much more low attenuation plaques, which are vulnerable, rupture prone. And if then in the patients who have low attenuation plaques and high Lp(a), those are the ones where in the next couple of years the event will occur. Mm-hmm. Whereas if you don't have low attenuation plaques, and even if you have high Lp(a), the risk is much less. So basically, Lp(a) destabilizes atherogenic lesions and really massively increases the risk for
that's
events.
The greatest risk.
That's the greatest risk, yeah. And Samia, you mentioned briefly the family screening. That has a lot of implications. How do you manage family screening?
Yeah, that's a very important question, Eric, because often we do not check the family members. So once we identify an index patient, now just having said that, I want to say that all the guidelines now and statements from experts
ask for family.
For family, and also for most of them agree that it should be done, LPA level should be measured at least once, probably only once in most people throughout their lifetime. So families, there's codominant inheritance of LPA from the father and the mother, and about 90% of it is genetically determined by the level.
Which in LDL is like 20 or so,
yeah,
right?
Yeah, exactly, much less. So that's in a way good, because then you can identify family members who may also have it and potentially screen earlier, identify them earlier.
And who does screen, you or general practitioner?
Yeah, anybody can, both. Anybody who catches that patient should really be checking it. I don't really rely on having somebody else do it. Yeah. Ideally, it should also be set up through hospital systems and through clinical laboratory. So there should be a collaboration, but I think we just haven't gotten there yet. We talked also earlier with the patient that there's, about a 40% or so inheritance. So if like one sibling is identified with it, the other sibling has about a 40% or so.
It's nearly the same as familial hypercholesterolemia, right?
Yeah, in some cases, those who have the very high levels, the risk can be equal to familial hypercholesterolemia.
Yeah,
exactly.
and cascade screening.
Yeah. So at about 4 or 5 times the general risk of the population, which is huge. Yeah. Eric, one last question for you. What do you think the future holds? Can you tell us about what's your prediction for the future?
Yeah, no, we're very happy. Usually you get a lot of comments, well, if we can't treat Lp(a), why measure? Now you were very convincing. We have to measure and it has consequence directly, but a little glance at the future. If you look at all the RNA targeting strategies, there's the antisenses like pelacarsen, and there's the siRNAs like olpasiran and lepodisiran.
And these all target the RNA.
And they all target the RNA. And the good part here, there are some others. There's an oral compound and there's others still in development. But if you look at the efficacy, it's been proven very difficult, right, to reduce Lp(a). The antisense, so that's the pelacarsen, it's furthest ahead with phase 3. They have an 80% reduction. Then the Cerna, the olpasiran, has a 98% reduction, and it's only once every 3 months.
And that's an injection.
That's a sub-Q injection, and hardly any side effects. And then the novel agents, I think the last one, which is now entering also a phase 3 trial, they claim to even go 1 injection per year. So if you have a more than 95% suppression, and you have very few injections, I think this holds a great promise to completely, maybe eradicate. And we are all looking forward to the endpoint studies from 2026 onwards, that we can hopefully now say we solved the problem of Lp(a) as long as we detect it.
Correct. Detection is key, because if you don't measure, you don't know. And are there any oral agents, Eric?
Yeah, I think there's 2. One is furthest ahead. Those data also are very promising, but that's still a little bit further away.
Okay, so to summarize for you today, we had a great discussion about why we're checking Lp(a), that the Lp(a) level is causal for cardiovascular disease and for aortic stenosis. It's dose dependent, so there's a graded risk increase. And in some patients, the risk can be as high as familial hypercholesterolemia. We also talked about how it's important to incorporate it into the patient's cardiovascular risk assessment. So we assess the patient's risk, whether they're in prime prevention, we can calculate their risk, or secondary prevention, and we can multiply the risk from Lp(a). Now you can estimate how much that would be based on online calculators, or you can go to some of the documents, papers to estimate that risk of how much you should multiply the Lp(a) risk with the cardiovascular risk. And if it's severely elevated, of course, we should always intensify the lifestyle measures and improve all the cardiovascular risk factors and make sure the patient is optimally treated according to guideline-directed medical therapy. But in addition, as Eric just summarized for us beautifully, the Lp(a)-specific lowering therapies are very exciting. They're currently in clinical trials for phase 3 clinical outcomes, and we're eagerly awaiting them to see if we can finally impact lowering Lp(a) and lowering cardiovascular disease events at the same time.
Well stated.
Our time is up, Eric. Thank you so much for that great discussion and for teaching us a lot about Lp(a). And thank you, the audience, for participating in this activity. Please continue to answer the questions that follow and complete the evaluation. And Eric, you did a great job in the time allotted us. So thank you very much.
Thank you.